Good evening, everybody, and a very warm welcome to this year's Late Summer School for Ultrasound. On behalf of Sonography Graz, we're happy to welcome all the participants here, all the collaborators and participants at our partner universities in Innsbruck, Zurich, Mannheim, Heidelberg, Bonn, Aachen, and Berlin. Actually, who are the three people here standing on the stage? So we're Vanessa, Johanna, and Leonard. We are voluntary tutors from Sonography Graz, and we're very happy to have you here today. What is more, we're more than delighted to welcome our honored guests tonight with us. Among them, Professor Marianne Brotmann from the Department of Angiology, Professor Friedrich Fruwald from the Department of Cardiology, Dr. Simon Orlob from the Department of Anesthesiology, three of them from the Medical University of Graz, as well as Mr. Max Fließer from MEDES and Mr. Gerald Auer, dedicated member of staff from the Medical University.
We are great. Okay, we are grateful for the help of our generous sponsors. As you can see here, the UH and the Medical University of Graz, who do not only support us for this event, but throughout the year. Furthermore, we want to thank GESPAG, MEDES, where we do get our ultrasound levels for, Schülke, ECA Medical, and the Vorarlberger Landeskrankenhäuser. We are a student initiative consisting of about 40 voluntary tutors. We'd like to emphasize on this point that we are organizing Sono4U in our free time. We are not getting paid and we're not employed at the Medical University. It's just our passion for ultrasound and the wish to carry further this passion to our colleagues that is our reward. Sono4U Graz was founded in 2013 by a group of enthusiastic medical students. One of them, our guest, Dr. Simon Orlob. Without the dedication of him and his colleagues back then, none of this would have been possible. What is more, we would like to welcome our alumni Mario and Franziska, who still support us even though they already graduated. We would like to take this opportunity to thank you for the contribution of the entire team. Thank you very much. We also want to express our gratitude to all of our speakers. They came from all over the world to share their knowledge and their experiences with us students. They do it on a voluntary basis and in their free time, which is unbelievably great. Thank you very much for your commitment.
And now, without further ado, it's my pleasure to welcome Professor Dr. Fruwald, who's kindly going to give us a short welcome speech. Thank you.
Okay. Good evening, everybody. Can you hear me? Yeah. It's an honor to be here with you, and when I got the invitation to give a few words to you, I didn't know that the lecture should be in English, so my notes are in German. However, when starting this Congress, this international convention, I've heard 60 people from here, 5 from abroad, some of them coming even from Sweden. So welcome to Graz. I would like to take you back a few years. I'm from the Department of Cardiology, and the treatment of the most important acute disease, myocardial infarction, has changed over the years. I would like to start with an anecdote showing the importance of sonography in detail echocardiography. A few years ago, treatment of acute myocardial infarction was not done by PCI, so with no catheter, no stent. but in the time before this, it was done by thrombolysis. This was an injection given by the emergency doctor or in the emergency department, and the idea was to open the vessel via thrombolysis, and the clot goes away in the coronary vessel. So a very experienced emergency doctor from the Department of Anesthesiology called us and said, well, I think I have a posterior myocardial infarction, but I'm not really sure. The patient has pain in the epigastrium and some ST segment elevation, but I'm not sure if this is posterior myocardial infarction. Should I do thrombolysis? And I said, if you're not sure, please don't do it. And then he brought the patient in. It was just a kilometer or two from the hospital. And we did an ECG, and the patient did not have posterior myocardial infarction because the ST segment was normal. So what did we do? The patient claimed pain in the abdomen, a little retrosternal pain, and we did an echo. And the patient showed a completely normal echo. So if you have a myocardial infarction, you always have wall motion abnormalities. Then we switched to abdominal sonography, and we saw fluid in the abdomen. And when checking the abdomen with the sonography, we saw that the spleen was ruptured. So it was very important to do the sonography before starting the definite treatment. The treatment was not thrombolysis. The treatment was explantation of the spleen. So this should give you a hint that sonography is of outstanding importance in the diagnostic workup. This is the 5th course, I think, and the first colleagues already work, and I just had the privilege to talk to some of them, and all are happy that they could do the Sono for You course here in Graz. So when I started working, I have been told sonography will be the stethoscope of the future. Up to now, it's not really the stethoscope of the future. If you think of older machines, you have here brand new machines, very, very elegant technique. But the sonography in the early days was huge, at least 120 kilograms. When you switched it on, it took at least 2 to 5 minutes before you got a picture, before you could use the machine. And the monitor was very small, not these huge monitors as you see here or in the back. They were tiny as this paper here. Sonography now and in the future is small, it's battery driven, it's mobile. You can use a laptop, a smartphone, or even a tablet. You can use the probe without a cord or with a cord, and it is definitely on its way to a bedside tool. So I hope you enjoy the Congress. I wish you all the very best for the Congress and all the very best for your personal future. Thank you.
Thank you, Professor Fruwald, for your kind words and for sharing your interesting experience with us today. Now I'd like to hand over to Mr. Max Flieser, who's from the company of Midas, and Midas is one of our long-standing and very kind sponsors. So thank you for being here. Thank
you. Hello, now you can hear me. Thank you very much for your very nice welcome words and the introduction. So we, as company Midas, we are based in Graz, just a few kilometers from here, and we are very, very proud to give support to you guys, to all prospective doctors, as everybody of you is sitting in this room, as well as on some monitors far away from here. And I think, please correct me if I'm wrong, it's the 5th time already. I apologize. We are allowed to support Sono for You, and I can say, and it's a honor to say, for company Midas, it's really a big pleasure to support Sono for You in Graz, because As you mentioned already before, ultrasound will be the new stethoscope in the future. And same as the last couple of years, we're doing it that way, that we don't provide you a high-end ultrasound as you would see it up here. No, not at all. This year we have 15 ultrasound machines in a couple of rooms, from the low budget segment, where you can get very poor quality, up to high-end units where you can see a lot of. So maybe if you have some questions, even in the next 4 days, my colleague Paul, sitting in the front row, will give you some assistance, as well as my person only. And you asked me before to keep the speech short, because you have a very tight schedule. I want to say thank you once more, and as we would say it at Mides, happy sounding. Thank you.
Thank you so much. It's really our part to thank you for your continuous and kind support. Thank you. So now, before we start with our first lecture, I would like to take this opportunity to give you a short summary of the upcoming days. Today, we'll learn more about the basics of ultrasound and the fundamentals of the anatomy that's behind it. Tomorrow, on Friday, we'll focus on the so-called eFast exam that is designed when treating a traumatized patient. On Sunday, we'll follow up with the so-called rush exam that is linked to a hypertonic and shock patient. And then finally, on Sunday, we will hear more about some advanced ultrasound applications. That is, for example, lung sonography and sonography related to cardiac arrest. Your hands-on sessions and workshops will take place in the afternoons. I would also like to take this opportunity to inform you that you, as the audience, do have the option to ask questions to our speakers at the end of every lecture. Same goes for everybody watching on the live stream. You can do so via the comment section either on Facebook or on Twitter, and we'll make sure that your questions get forwarded to our speakers. But now, without any further ado, it's my pleasure to introduce you to our first and very special guest, who came all the way from Melbourne, Australia, to be with us here today. Suean Pascoe is a highly qualified sonographer with many years of clinical experience. But in addition to her clinical work, she has now devoted her career to ultrasound teaching and ultrasound education. As the director of Zedu, she is now the head of a teaching facility that provides medical practitioners with the ultrasound skills they need. It's our honor to have you here today, to have such an expert in ultrasound education with us here. Please do give a very warm welcome to Suean Pascoe.
Thank you. Thank you. Thank you so much, and I'd like to thank the Sonography team for inviting me to speak. I always get really enthused by all the energy for the ultrasound that is in the med students. And hopefully today I can sort of put a little bit of context and scope around how you might be using ultrasound and inspire you to get really good at this, because there's good reason to be good at ultrasound. So in my opinion, ultrasound is the hero imaging modality. It's, I might be a bit biased, maybe, just a smidge, but it certainly beats CT and MR. They're expensive. It's really readily accessible. The price of machines has come down quite a lot now, and so it's really accessible for everyone. It's also a modality that you can do great things with and save lives, or just even just reassure a patient. And so we have my title of my talk is Breaking the Barriers Through Ultrasound, and it's kind of this tool that crosses all medical disciplines and allows you to break the barrier with your patient, because you have to get up personal and touch your patient, and allows you to communicate with your patient. But it also, because it's across all the disciplines of medicine, allows you to break down some of those barriers and those silos that exist between the different disciplines of medicine, if we can kind of put the politics aside. So, as Uncle Ben said to Peter Parker, with great power comes great responsibility. And I think that this is true of ultrasound. It can be a fantastic tool, a really fantastic tool. But in the wrong hands, it can be dangerous and it can lead to a lot of trouble. And part of that is making sure you're skilled, and part of that's making sure you're trained well to make sure that you get the right diagnosis and manage your patient in the right way so that you're not being dangerous. So I wanted to start with a bit of a personal story that sort of has confirmed my belief that every single medical graduate should have some skills in ultrasound. Some time ago now, right back at the beginning of the journey at Ultrasound Training Solutions, before we changed our name to Zedu, I personally had this trip to Sydney planned. So I get on a plane, going to a meeting to meet with our professional society, where we were arguing the case that sonographers could teach doctors how to use ultrasound at the point of care. So in Australia, we have sonographers, and they're like specialist technicians that just do ultrasound. They're not doctors or medically qualified. It's kind of, we come from a nursing background or a radiology assistant background, and then just specialise in diagnostic ultrasound. And so we were having this big meeting to argue the case that we were able to teach doctors how to use ultrasound at the point of care, because we were the experts in how to get good pictures and get a good picture so that the diagnosis was right. It was a big meeting, and we were anticipating a bit of heat and a bit of trouble. And I'll go to any sort of lengths to get out of some meetings, but I wasn't quite planning on this. So we landed, I touched down in Sydney, and caught a train out to where the venue was, and met our colleagues, and walking up the hill, and all of a sudden I felt this really sharp burst of pain in my tummy. And I was like, oh gosh, I don't know if I need to go to the toilet. I don't know if I need to be sick. I don't know if I've got a bug, but oh my gosh. But I pretended like nothing was happening because we've got this meeting. We went on up to lunch, and I had to convince the restaurant staff that no, I hadn't been drinking excessively at lunch, but I had been quite ill, and they're like, yeah, likely story. But, and sometime during the meeting, I kind of just slumped down on the chair and realised that I was lying down when my colleagues kind of said, don't mind Suean, she doesn't usually lie down in meetings. And I thought, am I lying down? I kind of sat up. And then we kind of walked back to, we'd done our prep and had the discussion, we walked back to have the meeting, and as we're walking back, I'm like, this is bad. I'm in a bit of trouble here. And so we get to the offices, and I remember their white couch well, because I was very worried about my dirty shoes on their white couch. And as I arrived there, I was kind of thinking, I think I need to go and see the doctor, because I think this is getting a bit bad. Wasn't a doctor. We ended up calling the ambulance, and as my colleagues kind of left the room, I said to the paramedics, I'm 6 weeks, 6 days pregnant, and I think this is an ectopic. And all of a sudden it became clear that the quick scan I had done on myself the night before, what I'd seen. And at the time, because I was preparing to go to the meeting and I had a 3-year-old running around, and I didn't have a full bladder, and I wasn't doing it on a conventional ultrasound machine like this sort of exam in my clinical practice we would do transvaginally and we'd do on a top-end machine. So I was a bit not so confident on a point-of-care system. And I thought, it's not quite right, but when I come back from that meeting, I'm going to go and get a proper scan done. And anyway, it turned out, no, I didn't get to go to the proper scan. I had an ectopic, and it had ruptured. So as I presented at the emergency department, my blood pressure was doing something like this, and it only got worse from there. I had an ultrasound machine that showed nothing in the uterus. It showed some free fluid in the right upper quadrant. It showed free fluid in my pelvis. There was fluid everywhere. I remember saying to the doctor who did the scan, can I have a look at the picture, please? And she said, oh, you're not going to see your baby, dear. I said, I know. Can I have a look at the picture, please? And she kind of turned it around, and I swore a lot because it was like, oh shit, I'm in trouble. I don't know if I'm allowed to swear, but I just did. And so then I had a very quick journey. I was in the emergency department only 25 minutes. And what was going to be laparoscopic surgery turned into an open laparotomy very quickly because I crashed and I was needing to be operated on really quickly. So I think of that journey, and I think if I had to wait for a formal scan, I wouldn't be here to tell you about my story. And I also think of that journey in the context of I probably would have ended up in the operating room anyway. But this way I went to the operating room and they knew what was going on. They knew what to expect. They're not just kind of going in there blind. And when you're the one they're cutting open, that's quite reassuring. But it's interesting because this story kind of continues the next day when my colleague, who had no idea what was going on, rings me. And I foolishly answer the phone because I just wanted anything to distract me from the fact I'm in a hospital. And she had a doctor who had been to one of our courses the week before and had learnt about FAST and AAA exams and a bit of heart. And this emergency doctor had then gone back to their workplace and thought that it was now appropriate with the skills FAST, AAA and heart to now do an assessment in the first trimester and to tell the patient, I think the baby, that there's a fetal demise. Look, we'll just make sure and have it confirmed by radiology before we send you for a D&C procedure. And so my colleague rang me, and this wasn't the first time we'd had this stern conversation, and she was angry. She said, "What are you teaching these doctors?" And we were not popular because we were teaching doctors ultrasound because it was a betrayal of our profession and, you know, why are you teaching the doctors this? We should be doing, sonographers only should do this. And so I don't know if it was just the amount of morphine that I had on the pump or what, but I kind of got a bit more adventurous in rebuffing her this time. And I said to her, look, they're doing it anyway. I want to teach them to be safe. I want to teach them about what their limits are and how to be safe using ultrasound. If they're doing it anyway, someone's going to teach them. I'm mindful of your comments as a sonographer, and I understand, and I'm kind of sitting on the fence. I'm kind of earning a living from this now. But all that just melts into nothing because right now I've been the patient and I couldn't care what you say. You're not going to win this argument with me. If we look at this purely from a patient's perspective, the politics kind of dissolves into nothing. So that was very early on in the journey of Ultrasound Training Solutions, or Zedu. And it certainly has inspired me to make sure that we're teaching doctors to be safe using ultrasound and teaching you where your limits are with ultrasound. So what I'm hoping to just get across in the next little while is the utility and scope of ultrasound, look at a couple of cases, ultrasound in action, and then just a couple of words on training to get you thinking about how you're going to get yourself skilled in this modality, because if you're good at it, it can really help. So as these machines have got more and more compact and cheaper and more accessible, and even small enough to put in your lab coat pocket, it means that you can, you know, do an ultrasound on just about anyone. And at some stage during a patient's journey through the hospital, any discipline of medicine might do an ultrasound on that person. And so it's become a really, really handy tool in your toolbox. You know, used to use the stethoscope, and now you can actually see what you're doing. You don't have to just kind of listen and hope. You can actually look. You used to do a clinical exam, well, now you can use the ultrasound to supplement that. And again, you can look and confirm what you're doing. And so if we look at what the International Federation of Emergency Medicine and how they define a point of care ultrasound exam, it's structured to answer a clinical question or a set of questions. It's a focused exam, usually performed at the bedside. This definition always amuses me because every ultrasound I've ever performed has been beside a bed somewhere. It's complementary to the physical exam. It's generally performed in suboptimal conditions. So when I see a patient as a sonographer, they're usually fasted, they've got the pain meds going, I can usually roll them around. You get to scan them in squishy beds, they can't roll around so much, they're in pain often, so the conditions that you're performing them under are not as ideal. And you know, you've got the lights up blaring, we turn the lights down so we can see everything clearer. So you get to perform these in suboptimal conditions. And the other definition is that it's not a replacement for a consultative radiology exam. And for me, a comprehensive radiology exam is an entirely different examination to the point of care scan. They have completely different aims and objectives. If we look at the scope of practice that the College of Emergency Physicians uses, you can use ultrasound in a resuscitative capacity. So as you're doing resuscitation on a patient, monitor your efforts at resuscitation, make sure they're working, and if they're not, try something different. You can use it to diagnose, much like Dr. Fluriard. I don't know, I can't say German words that very good. But use it, you know, is it the heart or is it gallstones? Monitor symptoms, to do therapeutic monitoring. So if someone comes in short of breath and you're giving them Ventolin, they had wet lungs when they got there, you can actually see whether that medication is working and whether the lungs are getting drier because of the medication, and monitor that in real time. And last but not least, for procedural guidance, there's a whole host of evidence out there that says that the procedures are much safer and more efficient and have better outcomes if they're guided with ultrasound. So the point of care exam is set out to answer a clinical question. You should be approaching the exam with an idea of what you think the answer is. So you're not going in there as this vague fishing trip. I haven't got any idea what's going wrong. Oh, why don't we pull out the ultrasound? That's not how to use it well. You want to have an idea in your mind. Is this gallstones? Yes or no? Is there fluid in the tummy? Yes or no? So if you're asking a question that doesn't have a yes or no answer to it, then it's probably a scan that needs to be done in radiology or a comprehensive exam. So it's a really structured exam with a binary outcome. The other thing that it allows you to do is manage your patients in a time-critical fashion. My journey through the ED was very much quicker because I didn't have to, wait for ultrasound and the formal ultrasound to come from radiology and around. But we can do scans and get answers in real time and change drug management and change the treatment plan on the fly based on the images that we're seeing. So if we look at a couple of cases in the emergency department, imagine that the bat phone rings. I don't know if you call it the bat phone here, but the emergency phone that says a really drastic case is coming in. And they tell you that there's a 20-year-old male who's had a stab wound to the middle of the chest, and he's coming in 20 minutes. So this is great, gives you time to prepare your chest tube trays and get the cardiothoracics team down and get everything prepared. Your patient arrives. He looks like this. And while everyone sits there and goes, swing into action, you realise that on that initial assessment, the air entry is even, that he's got the tubes in place, he's got equal air entry. He's doing reasonably well. They can't find a central pulse. And so now it's like, that looks pretty bad, that knife in the chest. Is this a salvageable situation or not? And so ultrasound in this instance can be used to demonstrate whether this is someone that is resuscitatable. I don't know if that's even necessarily an English word, but that if this is a patient that is savable versus someone that it's inevitable that this patient's going to die. So if this patient has a tamponade, then we can do something about it. But if this patient has pulseless electrical activity, it stumps. And so in this case, he did have a tamponade, so they could crack open the chest, they put a drain in, drained off the fluid, packed it up a little bit, sent him off to theatre, and he went home. He survived the injury, which is quite impressive. Another case where a 70-year-old gentleman presented to an emergency department sort of kind of on the edge of Melbourne. So it's not quite the country, but it certainly doesn't have the facilities of the big city hospitals. So they don't necessarily have a CT scan there, and they don't have surgeons on call there, and so it's kind of the first stopping point for the people further out in the country, and then decide which big hospital that they need to go to. And so he kind of presented and is feeling a bit unwell, a bit hot and cold flushes, had a bit of abdo pain for 24 hours or so. And whilst he was in the emergency department, it starts getting sicker, and they thought the doctor who was looking after him is an ultrasound enthusiast, and he was like, I'm going to use the machine, I've got one. And so what he finds is this 6 centimetre aortic aneurysm that's dissecting. Did a couple more. You can see the dissectional flapping away there, and it gets a bit scary. And probably a bit of fluid that it's leaking as well. Use the colour to demonstrate that that was the aorta and not the vertebral body or something else going on. It definitely was the aorta. And so then he proceeds to go, holy moly, we need to get him to a bigger hospital that can cope with this, and has that political argument trying to convince the hospitals that he needs to fly them to, will you take this patient? And you know, there's a bit of argy-bargy going on. They're like, no, you have to define whether this is a type A or a type B dissecting aneurysm. He's like, can I just get him out of here and somewhere else that you can do something about it, regardless what it is? Anyway, unfortunately for this patient, he died in the emergency room just as the helicopter landed on the helicopter pad. But he went from, you know, just feeling a bit unwell to really, really sick very quickly. Another case in the emergency department. Imagine this is your grandma. Imagine she's a bit doddery. She's fallen over, broken her hip. Her x-rays kind of look like this. She's already spent a few hours on the floor before someone found her. So she's in a bit of pain. And so in the emergency department, they can now do an ultrasound-guided femoral nerve block to manage her pain. And so it becomes a completely different hospital experience for grandma because she's not in as much pain anymore. And so in anaesthetics, whether it be a simple nerve block in the emergency room as a pain management tool, because she mightn't be able to go to surgery for another 24 hours yet. So if you can keep on top of the pain and keep her in a better position, she's going to have better outcomes after the surgery as well. So, you know, the emergency physicians can do simple nerve blocks, but the anaesthetists, previously, the way they used to do it, I remember my husband looking at this and going, what, they just hack and saw until they touch and the leg wriggles? And then that's how you know you're in the nerve? And yeah, pretty much. Really? Why don't they use the ultrasound? Well, now they can, obviously. You know, not so many nerve stimulators. But the other thing, using ultrasound in anaesthetics, it means that you can decrease the volume of anaesthetic agent that you're using. You can be more precise with your placement of the agent, and so you can get a better nerve block because of it, and also have less systemic toxicity because of less anaesthetic agent. So here's a case where they didn't really. So 65-year-old guy who went for a routine sort of elective knee replacement surgery. And they didn't have ultrasound in their anaesthetic department. And so on this one, you can see this white blob here next to the round black circle. That's the femoral nerve. Now, they're pretty close together. So it's easy to see. I look at this. As a sonographer, I've scanned thousands of DVT studies and had never ever seen the femoral nerve until we had to learn how to teach the emergency physicians how to do a femoral nerve block, and all of a sudden it's like, that's a big nerve. It's always been there. I've never seen it, but I was never looking for it. And then I wonder, how the heck do they ever get that in without getting it in the artery all the time? And I know myself, I had a total knee reconstruction, and I had a femoral nerve block for post-op pain management as well. And I remember asking the surgeon, how do I know you're going to put it in the right spot? And he said, oh, well, you think about it, you're medical, think about it. And he left me stewing on it for like 3 hours. And of course, I'm a patient now. I don't think when you're a patient. And then I said, no, you're going to have to tell me. And he said, oh, well, we withdraw back, and if we get blood, it's in the wrong spot. Good. So going back to our 65-year-old guy who's had elective knee surgery, he's had a blind femoral nerve block, except 20 mils of ropivacaine has been injected into his femoral artery, direct route to the heart. So he arrests on the table. So the emergency team gets that was in one of the regional hospitals, so he gets evacuated to the Metropolitan Hospital, spends 3 weeks in intensive care with multi-organ failure, goes home without his knee reconstruction surgery, and has a very different quality of life now because of this multi-organ failure, all for the sake of using ultrasound and being able to see where you're putting the nerve and not make that mistake. In the intensive care, again, someone who's had an elective procedure, so a healthy patient who's electively had their aneurysm repaired. She's 1 day post-op, all's going well. And then all of a sudden she collapses. And so the routine advanced life support procedure is, I understand, I've never had to do it obviously, but I understand your first step is, give them adrenaline and along the way after you've checked their airways and all that, but then adrenaline first and moving right along. But again, in this case, there's a doc there who is a bit of a dab hand with ultrasound, and he said, she's had an aneurysm, let's just see if it's extended up or see if there's any problems because of the aneurysm. And so what he sees is this. And in this particular instance, we have an empty heart, and because there's not enough volume in the heart, the mitral valve leaflet is obstructing the left outflow tract and is obstructing flow of fluid out of the heart. And so giving adrenaline in this case is making the heart pump harder and is making this situation worse. And so in this life and death situation, this patient's gone flat, giving her and following the standard procedure actually makes her sicker, whereas we can see with ultrasound and just have a quick look and realise, you know what, we just need to put some fluid up. Let's fill her heart a little bit and it'll fix the problem. And that's all it took, but it was very counterintuitive to what the normal process was. But they might have just been resuscitating this patient for ages before they kind of got to, well, we're right down the bottom of our list of options and let's try some fluid now. So you can get to fixing the problem sooner rather than later. In family medicine, ultrasound can play a part. It can be as simple as finding a foreign body. Foot, hand, foreign bodies are notoriously tricky to find and dig out, and you can use ultrasound to guide the removal. You can use ultrasound just to find it and then cut down on it, whatever your preferred method is. They're quite easy to, some foreign bodies are really, really easy to see on ultrasound. Otherwise, it's kind of like hunting for a needle in a haystack. It might be as simple as the pregnant patient who's had a bit of bleeding, who just needs reassurance that, yes, this baby's in the right spot and there is a heartbeat. And then they can relax and stand down from all this anxiety and kind of go back to enjoying their pregnancy again. And that no, that's not, if the baby's in the right spot, that's not a life and death situation, but it certainly makes a big impact for that patient from an emotional point of view. And if anyone knows anyone who's been pregnant women are particularly vulnerable and particularly prone to being kind of emotional, and especially when you've got babies involved. So being able to say, no, there's a heartbeat and everything looks okay, can really change the pathway of that pregnancy. It might be that your 40-somethings have decided it's time to get fit again, having their midlife crisis, and they start go running, and they have the classic sort of presentation, I felt like someone kicked me in the calf. And so now we need to figure out, is this a torn medial gastroc or is this a torn Achilles? And so it's a really simple diagnosis. If it's a torn Achilles, they need surgery. And the sooner that they get surgery, the better the outcome for that patient. If it's a torn gastroc, go home, rest, ice, elevation, compression. So in this one, we can see some tendinitis in the top pictures, and in the bottom pictures, you can see the break in the tendon and it's a torn Achilles. And again, a really easy sort of scan to perform where you can see a torn medial gastroc muscle. So all that's great, but you've got to get to the point where you can recognise this stuff and use ultrasound responsibly and use it well and make the right decisions and optimise your image well enough and get good enough pictures so that you get the right diagnosis, because without a good image, you can't get a good diagnosis. So you need to understand how to use the the machine well and to get good pictures. And that's half of it. Then you need to know how to manipulate the probe so that you can get the best window. Like I said, without a good image, you can't get a good diagnosis. And if you haven't got a good diagnosis and the right diagnosis, then you can manage the patient in the wrong way. And so that requires training. It reminds me of a case where I was at the Children's Hospital and I was working for one of the equipment manufacturers, sort of locuming for them, doing a day and filling in. And they were trying to sell the machine, so they needed someone to stand there and show people the buttons. And I'd been given very explicit instructions, you're not to do heaps of training. That's not what we're there for, that's not what we're paid for. And this case for me was professionally really, really challenging because there's this 3-year-old kid who's 3 days post cardiac transplant. I watched 4 doctors come in and use the ultrasound machine. Well, the ultrasound machine was in the room. And I watched 4 doctors make 13 punctures and progressively crash the vessels on both sides until they called the big boss, who forgot that it just went not using the ultrasound and did it blind and got access on this kid. And they were all really cross at the machine. And it was hard because I'm like, it's not the machine's fault, it's yours, and I really want to tell you that, and I can't. But it just illustrates that, you know, just because the ultrasound machine's in the room, that doesn't fix the problem. I always love it when a patient says to me, geez, these machines are clever. And I feel like just going, why don't we just let the machine do it? So imagine if it can be just the machine that does it, then yeah, they are clever. But the machines are nothing without you holding the probe and you getting the pictures. So it's the operator that makes the difference. It's you that makes the machine sing, and it's you that makes the diagnosis. And so it's really important to bear that in mind and think about how you're going to get your training. There's a lot of material on the FOAMED world. On our website at ultrasoundtraining.com, we have a FOAMED tab where there's over 90 different resources of free ebooks, websites with case studies. There's all sorts of stuff. There's a Phantom compendium there that's got just about every single recipe that's ever been printed by anyone who's published an article on how to build a Phantom. Work your way through them, that's quite fun. There's a whole lot of education available for you out there that is free. Some of it's really good, some of it's not so good. There's some paid stuff that's really good and some that's not so good. The problem about learning ultrasound on a video is that it's only half the picture. So I want you to think about this for a minute. Imagine you're going to learn how to do the piano. So you think, you know what? I'm going to watch a YouTube video on how to play the piano. Now, I think we can all agree that we can sit and watch a YouTube video and be able to say, he can play the piano really well and he can make lovely music, and they're really bad at the piano. And we can, if we watch enough videos, we can tell who's a good pianist and who's not, who's practiced a lot and who hasn't. But then you might pull up a lesson on how to play the piano. And if that's all you do, and then you expect that you're going to go and sit down at the piano and all of a sudden be able to play the piano, then you're kidding yourself. And ultrasound is like that. It's easy for us to learn and watch others and recognise others who are good at doing ultrasound. And it's easy for us to recognise patterns when we are watching others who are experts at getting the pictures by watching them. But you can't learn how to do ultrasound entirely by watching a video. There's a whole lot that you can learn, how to use it or when it's appropriate to use. You can practice your pattern recognition, what's normal, what's abnormal. You can refresh yourself on the technique. There's a lot that you can learn. But the crux of it comes down to having that probe in your hand or sitting down at the piano and trying to make something that sounds like music. And so when you're thinking about how to get your ultrasound training, it's important to think about practice and drip feeding. You can't just come to a conference for 4 days now and think that at the end of 4 days you're going to be an expert and you're going to go away and play the piano like a concert pianist. It's a joke. It's taken me, I'm still working on my ultrasound skills, and I've been going at it 20 years. And it's always a work in progress. And ultrasound's a real art form. So you need to drip feed, like if you're growing a new crop, drip feeding your new crop or drip feeding your new skill and doing multiple short bursts of practice is going to be far more beneficial in developing your skill than if you just flood the crop once every 6 months or once every 2 years or whatever. Flood it and build up and re-inspire yourself, sure, but think about how you're going to practice this day by day to develop the skills over a long time. Practice puts brains in your muscles. And it is something that you have to practice, and you have to work at developing this skill. It doesn't just come easy because you've watched a video. You have to actually hold the probe in your hand and develop the skills. So before I wrap up, I just wanted to throw it out to the floor there for anyone who has any questions.
Yes, are there any questions in the room? No questions so far. I'm also going to check the live stream if anybody has got some questions there, but as it seems, no questions right now.
I never know if that's a good thing or a bad thing.
But you do have a question. Yes, please. I'm just going to hand you the microphone.
Hi, Suean. Hi, Suean. How are you?
Great.
Question from a fellow Australian. What do you think the most basic or one of the easiest skills to pick up is when someone first starts learning ultrasound? What do you think one of the first examinations they should learn is?
I think one of the most useful and one of the easiest ones that sort of teaches the orientation is probably vascular access. And performing lung is easy, interpreting lung is harder. Interpreting images and then managing is harder, but the actual getting the pictures is pretty easy. You know, a fast scan is always popular, and it sort of forms the staple of many beginner courses because people want to know how to do it when patients are crashing, but it's not necessarily the easiest thing. I start with scanning the bladder because it's a fixed structure and it doesn't move, and it's pretty uniform in shape between person to person, and you know, it's not as prone to pathologies and stuff as some of the other organs, like an aorta, for example. You've got to contend with bowel gas. If you've got a bigger patient, it can be hard. And then if they've got a curly one or pathology, it can be very confusing. And so it's not necessarily a simple study either. So the vascular access in terms of its utility, being able to get a line in a hurry, but also just the probe moves are quite simple. And it also just teaches you that the fine, you know, the big movements and then the fine detail movements, that you can sort of finesse that stuff on something that's kind of stays in the one spot.
Thank you.
Well, I'm glad we do have a vessels workshop right over there, and all of you will have the opportunity to practice these skills in the upcoming days. Well, thank you so much for your wonderful... I
was going to quickly sum up and wrap up sorry, Vanessa, now my battery's run out, which is a real nuisance, but anyway. So I started this talk with ultrasounds breaking down barriers. I want to imagine a world where politics and this sort of interdisciplinary fighting, oh no, this one's working, that the politics didn't matter so much, and we just strictly looked at this from a patient's perspective. And certainly my own personal experience has been supportive of the fact that I think every medical graduate should have basic skills. Having said that, you need to be aware of how important it is that you are skilled in it and that you develop the skills really well, because if you just be a bit of a cowboy with this, it can be quite dangerous. And so with great power comes great responsibility. We owe it to our patients to get good at it. And if you're good at it, you can be the difference for your patients. So thank you very much.
Thank you very much. do have a little present for you, a thank you gesture. Thank you for coming all the way from Australia to us. It's some regional Austrian goodies. I hope you do enjoy.
Oh, thank you. Yes, this looks really nice. Come in.
So, following this very inspiring first lecture, we can use now our motivation to focus intently on our next topic, the sono basics. They are, after all, the basis for the next days. So, the lecture will be given by Kerstin Drechsler, who is one of our most experienced tutors. Currently, she's studying in her 5th year of medicine, and she's part of the management team of Sonography Graz. By ÖGUM, the Austrian Association for Ultrasound in Medicine, she was certified as tutor for ultrasound. Let's have a round of applause for Kerstin Drechsler.
So thank you very much, Johanna, for your nice introduction. And in the following about 30 minutes, we will really try to elaborate on a basic understanding of how sonography will actually work. And I actually do hope that after having listened to this lecture, you will have a good ground base for the upcoming days. But before I actually want to start about sonography, we're going to make a trip into the animal kingdom and talk about bats. Because the way bats will navigate will really help us in understanding how ultrasound works. So basically, everything a bat does is it produces a high-pitched vocal sound with its vocal cords, and then this high-pitched sound will travel through the air until it will eventually meet an object. It will bounce off this object and then travel back as an echo. And everything a bat does is counting the time between the emission of the wave and the reception of an echo. And by counting the time, it can not only calculate the distance to the object, but also the size of the object, the shape of the object, and even the direction the object is heading to. So in case of sonography, we really don't have any bats sitting in our transducers, but we rather rely on crystals. Those crystals have 2 main properties, and they are very useful for sonography. So the first property will be that if we apply some electrical potential to the crystal, it will generate an ultrasound wave. And the second property is that if the crystal will face mechanical stress, it will then produce an electrical potential. And what we are going to do in the upcoming minutes is we are producing a sonographic picture by ourselves. And the first thing we will do is actually we apply some electrical potential to the crystal. And the crystal will now produce this ultrasound wave, which will travel through the body. It will eventually get reflected at an interface. And then it will travel back to the crystal as an echo. And now the crystal will generate some electrical potential. And by now we know that it's basically just the sending process of an ultrasound wave and the reception of an echo. But I have also talked about interfaces, and if we forget about all the physics behind it, you just have to keep in mind that an interface will be all those regions where tissues with different properties will meet. So there will be interfaces throughout our body. And what we keep in mind is that the higher the mismatch in tissue properties will be, the higher will be the reflection. And the more the tissues will resemble, the lower will be the reflection. So if we're reviewing this process, we are seeing a video, and we are seeing that we are in a constant cycle of emission of waves and reception of an echo. And the ultrasound wave will maybe encounter our first interface. It will generate an echo, and then it will encounter a second interface where it will generate an echo. And again, like the bat, everything an ultrasound machine does is counting the time between the emission of the wave and the reception of an echo. And what we're going to do now is we're going to transform this electrical potential we acquired with the crystals to transform it into a picture. And the first mode we can display our pictures with is the so-called brightness mode. The B mode depicts tissues, and it's actually, I think, the mode you know if we are talking about sonography. So what will happen is that we will assign every amplitude of an echo a different color. And the higher the amplitude of an echo is, the brighter it will appear on the screen. So for example, we are seeing a very, very bright structure at that place, and that is just a creation of a really, really high amplitude echo. And if there is a tissue that will not generate any echo at all, we will just display it as black. If it's somewhere in between, so we will generate a low amplitude echo, we will display the picture or the tissue as gray. But actually, I don't really want to talk about black and white and gray, because as we are scanning, we don't really examine the color of our organs, but we are rather examining the echo texture of an organ. So we are scanning the ability of an organ to generate an echo. That's why we will call all those gray structures hypoechoic, so they will generate a little echo. We will assign all those really bright structure the term hyperechoic. And if there is no echo at all, we will just say it's anechoic, so it's producing no echo. And what we keep in mind till now is that bones and air, they will be hyperechoic. All the soft tissues will generally be hypoechoic. And fluid, it will absorb the ultrasound waves, but it will not generate any echo. It will be black. And sometimes we really want to compare the echo structures of two organs. And so if they resemble quite a lot, we just tell that they are isoechoic. And the next mode I'm going to talk about is the M mode. And the M mode is really difficult for many people to understand, so we're going to take a different approach. Imagine you're a sailor and you're on a ship. The ship is anchoring, so you are not moving. And then there is a whale. The whale is swimming in the sea, and it's actually passing below the ship. And then you're the sailor, and then you think, oh, it would be great to actually look what happens below my ship. But I unfortunately only have a camera. But what I'm going to do is I'm going to place this camera directly below our ship, and we will just take a lot of pictures, and the camera will stay in place. So what will happen now is that the camera stays at this place, but with a very high frequency, we are going to take a picture of the same place. What will happen now is that the whale will actually swim below our ship, but we are having a depiction of the motion in relation to time. And that's actually what an M mode does. So in sonography, we would just have a random P picture. In that case, it would be our mitral valve in the heart. And then we're actually taking a line, and we want to examine the movement of a structure at this specific line. And what we are going to do is take a lot of pictures and assign these pictures in a row. And so we are having a different mode in which we really can analyze movement really, really well. That is called the M mode. In that case, we're seeing the movement of the mitral valve. And at the beginning, it's really hard for beginners to understand. But if you just take the approach that we will display the movement of a structure, that should be fine for now. So now we have talked about how to generate a picture, which modes we can actually use. But there is still one more point I really want to talk about, and that's frequencies. So as we are scanning, we have to have transducers, and there is a wide variety of transducers, and we always have to choose the appropriate one. And the transducers, they will vary not only in their shape and in their size, but also in their frequency. And something we have to keep in mind is that high frequencies will result in a really, really good resolution, and that low frequency probes will result in a relatively bad resolution. But as a drawback, high frequency probes will have a very, very low penetration depth, so they will get attenuated really relatively quickly. And low frequency probes, as an advantage, have a very, very deep penetration depth. So what ultrasound is basically about is that we always have to find this compromise between penetration depth and between resolution. As now we're going to talk about the three most important arrays we will use in the upcoming days. It's the phased array, the curved array, and the linear array. And as I told you, they will not only vary in their shape, but also in their frequencies. So the first one is the phased array. It produces kind of a slice of pie-shaped image. We're having the curved array, which will produce a trapezoidal field of view. And we're having the linear array, which will produce a rectangular field of view. So first of all, let's talk about the linear array. It's pretty easy to understand. And in the linear array, we're having our crystals aligned in one row. And those crystals, they will emit the ultrasound waves. They will travel through the tissue. And the major plus of the linear array is that we are having a beam density that is linear throughout. And also, linear frequency probes tend to be high frequency probes. That's why we will have a really, really good resolution, axially as well as laterally. And this will help us in really examining small parts, in examining arteries, veins, the thyroid glands, muscles, or even the pleura. And maybe tomorrow you will hear a lot about pleura evaluation with sonography. So I think you should keep that probe in mind. The second probe we're going to talk about is the phased array. Imagine you want to scan the heart, but really the ribs are in our way. And I have to tell you that bones and air, it's not really made for ultrasound. So we really want to avoid the bones. And if you think of your ribs and then think of your intercostal spaces, you will realize that your intercostal spaces are pretty narrow, but still you want to get a good picture of our organs. So what we're going to do is we're going to take this small phased array, and we have a really, really small focus zone. But what we're going to do is that the focus zone will constantly change its position. And as it's changing its position in the cycle, we are getting this slice of pie-shaped image, which is very, very useful because at the superficial area of the picture, where there is the intercostal areas, and we don't really want to examine that, the field of view will be really, really narrow. But as we are scanning the heart, and as the penetration depth increases, our field of view is getting wider. And so it's really, really, really useful in examining the heart, for example. And in the upcoming days, we will need it for the rush evaluation of the heart. The last array I'm going to talk about is the curved array. So the curved array is somehow a compromise between the linear array and the phased array. It has these piezoelectrical crystals aligned on a curvilinear surface. And as the ultrasound waves get injected, they will diverge. And the deeper the penetration depth of the picture will be, the more the ultrasound beam will diverge. And that leads to a really, really low, so I'm not seeing the pointer. Right now we're seeing the pointer. And what we're seeing is a very, very low lateral resolution as we're going deeper into our body. But imagine you're scanning the typical Austrian. So the typical Austrian, if we're scanning the abdomen, he will have quite an amount of belly fat. And so if we want to do ultrasound, first of all, we have to parse a lot of fat. And that's why we will need a low frequency probe with a wide field of view as we are penetrating the tissue. That's why the curved array will be especially useful for the evaluation of the abdomen. The last theoretical point I want to talk about are artifacts. Because if you think of artifacts, you will think they're a nuisance, but that's not totally true in sonography. In reality, in sonography, artifacts will be a very, very valuable diagnostic tool and aid, at least most of the time. And so I first of all want to define what artifacts are. So artifacts are images that do not actually represent the tissues being scanned. And they arise from a variety of different phenomena, such as reflection, absorption, acoustic scattering, and reflection. But I don't want to talk about physics. What we just keep in mind is that they do depict reality. So sometimes it might be really, really hard for us to actually distinguish reality from an artifact. And so what we're going to keep in mind is that artifacts, they will shift their position as we are moving the probe. And real structures will not change their position in our body only because we move our probes. So try to keep that in mind for the upcoming days. And now I want to talk about 4 specific artifacts which seem very important for me the upcoming days. So the first one is posterior acoustic enhancement. And what we are seeing is we are having some fluid-filled structures. We know it's fluid-filled because it's anechoic. And then behind those fluid-filled structures, we have a relatively hyperechoic zone. And it's called acoustic enhancement. But in reality, the ultrasound wave will not really get enhanced. Instead, it will get less absorbed. And as it's traveling through the fluid-filled cyst, for example, it will not get absorbed, it will not get attenuated, and that's why it will have lots of energy behind the structure and will appear relatively bright. That's a very, very valuable diagnostic tool because it can lead us to the differential diagnosis of fluid-filled cysts or vessels and so forth from other structures. However, that's not 100% specific because lymphomas or even hepatocellular carcinomas would always or sometimes even do that. The next artifact is acoustic shadowing. So imagine you're sending this ultrasound beam through tissue. It will eventually encounter a stone, for example, or a bone, or air. So what will happen now is that all the energy that is encountering the stone, the bone, or the air will either get reflected or it will get absorbed. And so as all the energy is getting absorbed or reflected, there will really be no energy that is passing through the stone. And if there is no energy, we can create no echo. And that's why behind those structures that will generate a lot of reflectivity or a lot of absorption, we will have anechoic regions. And this can be really, really helpful as well in diagnosis. For example, we are thinking of the liver here, and that will be the gallbladder. And then we are having some structures here. They seem pretty heterogeneously. And so our differential diagnosis, maybe it's polyps, maybe it's a tumor, maybe it's a stone. But in that case, we are having acoustic shadowing. And so acoustic shadowing would be, in that case, really pathognomonic for gallstones. The next artifact is reverberations. So sometimes, if we are sending out an ultrasound beam through the tissue, it will eventually encounter a strong parallel reflector. And what it does now is that it will get reflected and travel back and forth between the transducer and the first strong parallel reflector. However, the ultrasound transducer does not really know that the ultrasound beam is only traveling back and forth. So what it does is creating these equally distant parallel lines that are getting less energetic the deeper it will be displayed on the screen. Those reverberation artifacts, which will look like this in reality, are really, really helpful. For example, if we're scanning the lungs. So we will talk about that on Sunday as well. And then there is one last artifact which seems very, very important to me. So sometimes we're sending out an ultrasound beam and it travels through the tissue, and then we are having an oblique structure. And this structure will have a high reflectivity, for example, the diaphragm. So what we are doing now is the ultrasound beam travels to the diaphragm, but it will not get reflected, but rather it will get refracted, and it will change its direction of propagation. It will travel through the tissue. It will finally encounter a nodular structure, for example, be reflected again, and then travel back to the ultrasound transducer. However, the ultrasound machine does not really know that the ultrasound beam is getting refracted. But the only thing it realizes is, the echo is returning relatively late, so it must be a deep structure. And the result of that is the so-called mirror imaging artifact. So in case we are having an oblique structure that has a high reflectivity, we will create a mirror image. In that case, that will be the real liver, and we are having a nodule here. And what we are seeing is somehow a mirror image of the liver, and we can even see the nodular structure. So in that case, that would also be not only a nuisance, but it will be very, very helpful. But we will talk about it tomorrow. And so I think everything you have to know is that the mirror imaging artifact will occur, for example, as we are scanning the right costodiaphragmal angle. Now, I've talked a lot about fiery, but still we want to be a little practical, at least. And imagine this bluish structure will be an organ. So basically, ultrasound is a cross-sectional imaging technique. So all we're going to do is we're creating cross sections. But ultrasound is really, really cool, because unlike a computer tomography, where we can only generate those transverse cross sections, we can just create any cross section we want with ultrasound, as long as we have the acoustic window. And that's what makes ultrasound so special, because we can really generate this three-dimensional image and depiction of an inner organ and even a pathology. And now we have talked that ultrasound is a scanning technique that makes cross sections, but still we don't really know how to use an ultrasound machine. So we would look at an ultrasound machine, and right now maybe you think, how the heck will I ever be able to work with that? There are just so many knobs. I would not remember that. But if you're thinking of watching TV and you have a TV remote, there will be a lot of buttons, but you won't really use them. There would maybe be like 4 or 5 or even 6 buttons you would use on a regular basis. And that's why there is an ultrasound TV remote. It's more like the Apple version of an ultrasound TV remote. So we are having 5 buttons you will really have to know in the upcoming days. We have talked about M mode, we have talked about the B mode, so I won't cover that. But imagine you're scanning and you're searching for the kidneys and you just don't find them. But eventually you're finding the kidney. So the first thing you're going to do is you're going to press the freeze button, because then you're safe to analyze the picture in freedom. You can't lose the structure again, and it will really ease your level of stress in that case. The next point is we want to talk about depth. So it's not working. It's not working. So we're just waiting a little. And to just talk about it anyway. So in ultrasound, you can always adapt the penetration depth of tissue. So if you want to scan an organ that is pretty superficial, you won't really need 20 centimeters penetration depth. So if you're scanning a thyroid gland, maybe 5. Okay, it's not working anymore. Maybe there is a solution. Kannst du weiterschalten? Dann schaltest du einfach weiter. Okay. Joanna will now turn on the presentation again. And now you can change the slide. So as we're scanning out with ultrasound, there's basically one thing we can do is we can basically adapt the depth all the time. So if we're scanning superficial structures, we don't need 20 centimeters penetration depth. And if we're scanning deep structures, we really need 20 centimeters penetration depth. So it will always be important to actually adapt the penetration depth so you get the best possible picture. And what you're going to do is you center the region of interest. So in that case, it will be your kidneys. And you really try to place it centrally so you can really evaluate it. But I think that's fine now for depth, so we're going to talk about gain. So imagine you're listening to radio, and then there will be this one specific volume you really like to listen to radio to, because you will understand everything, but there will just be no interferences, and it will not be blurred or distorted. And then someone enters the room, and he will turn up the volume. But what happens is that you won't really understand what they're talking about. It will be really, really loud, but you don't get the real message of the picture. So if we are, the same applies basically to sonography. If we are turning up the gain, so the overall brightness of the picture is that we will eventually encounter a picture like that. It will be blurred, and it will be distorted, just because the gain is too high. The contrast will be really, really bad. So we have to adjust the gain. And the same thing is if you're listening to the radio and then someone enters the room and he will turn down the volume, what happens is that at one moment you won't be able to get what they're talking about anymore, just because it's too silent. And that's also the reason, or the same applies with gain. If we're putting the gain down too much, we just won't be able to see anything. That's why the right gain, it will be somewhere in between too high gain and too low gain, but really that's specific and it relies on you. So there are some people who like to listen to music louder and some don't, and so it's up to you how to adjust the gain. And now I want to ask my colleagues Martin and Patrick on stage. We will show you how to move an ultrasound probe, because what's really important is that as we are using an ultrasound transducer, we really have to have a common vocabulary we talk with, because otherwise it will be really, really hard for us to explain, and it will be hard for us to talk about doing ultrasound. So Martin won, and he will actually do the ultrasound examination. What Martin will do is he will apply some jelly on the abdomen of Patrick, so we can reduce the acoustic mismatch between our tissues, and so we can get a good image. He will now acquire a picture of the Morrison pouch, which is, I can't show it, but it's the room between the liver and the kidneys, so you might be able to see. And what the first movement he does is he will slide the probe, so he will just move it to eventually reach the gallbladder. And sliding, it's just a movement of moving the transducer in one row. He will now move to the gallbladder, and he will eventually find the gallbladder. There she is, the anechoic structure. It's a fluid-filled cyst, so it will appear black on the screen. We are seeing the liver next to the gallbladder. And what he will do now is he will rotate the transducers to acquire a short axis view of the gallbladder. Somehow we have lost the gallbladder, I think. But Martin is on his way to look for it. So we are having the gallbladder in a long axis, and we are rotating it to get the gallbladder into a short axis. This will be our second movement. We can not only slide the probe, but we can also rotate the probe. And here we have the gallbladder. Unfortunately, I can't show it in a cross-section. And as we're doing an ultrasound, we want to get really a three-dimensional image of our organ. So the next movement, what Martin will do is he will angulate the probe. So angulating really helps us in changing the angle we will penetrate the tissue. And by angulating the probe, we can get different cross-sections of our organs. And in our minds, we can just create a three-dimensional image of the gallbladder. And as he's now again in a cross-section of the gallbladder, And then there is one last point I want to talk about. It's called heel-toe tilting. So heel-toe tilting is basically lifting off one part of the surface of the transducer. So he will now lift off the first part of the transducer, and now he will move off or lift off the second part of the transducer. And this is really, really helpful if we're having bad acoustic windows, for example, and if you really want to examine a structure in detail. It can be really, really useful to actually have different angles we can scan with. So what we were talking about now is a translational movement. It will be sliding. We can rotate to get from a cross-section to a long axis, or from a long axis to a cross-section. We can angulate our probe, and we can do heel-toe tilting. Thank you very much, Martin. Thank you very much, Patrick. That was it. That were the basics of sonography. I really do hope that you understand quite well now how ultrasound will work, that we will have this emission process of a wave and a reception, that we can display it in an M mode and in a B mode, and that we will have different transducers that we can work with, that we always have to find a compromise between penetration depth and between resolution, and that we have artifacts, but they are no nuisance, but they are rather a diagnostic aid. Thank you very much.
Thank you very much. Thank you very much, Kerstin. Are there any questions from the audience? Okay, well,
No, that's okay.
oh, there is a question. Okay.
What are the limitations of ultrasounding in terms of resolution? Like, what's like the smallest object you could picture on that?
That highly depends on the frequency. So the higher the frequency is, the worse will be the resolution. But if you have a 5 megahertz transducer, for example, your resolution will be about 0.3 millimeters.
Cool.
So it's really, really good. But that's only the axial resolution. So the axial resolution is the resolution in the direction of propagation. But then there is also the lateral resolution. So it's the resolution perpendicular to the direction of propagation. And it will be usually 2 to 3 times worse than the axial resolution. So if we have a really high-end transducer, for example, we might have a resolution of 0.1 millimeters in axial resolution. But in lateral resolution, so perpendicular to it, maybe 3 to 4 millimeters. And then we also have a specific depth of our cross-section. It will be the elevative resolution, and that is not that good. So we're always having not only one beam, but rather, or not only one line, but rather a beam of ultrasound. So that's the main limitation about it.
Okay, and one question more. For beginners, it's often difficult if there is a lot of gas in a bowel. Do you have a tip for beginners how to cope with that?
Yeah, to be honest, bowel gas is a very important limitation if we're doing ultrasound. So if it's not a really emergency situation, you can try to compress the bowel, and what happens is that the bowel might actually change its position. So you might get a good acoustic window, or you might try to move your probe and getting another acoustic window. But to be honest, in my eyes, if we're having a lot of bowel sound and we're in emergency situations, I would rather rely on a computer tomography, because what is really important is that you can actually say, oh, I was not able to find anything or to analyze anything just because the way of examining was limited. And so it's really important to stay true about that. Ultrasound has many limitations we have to face. But still, in an ultrasound situation, most of the times, we won't have to face the problem with bowel gas.
Thank you very much for your lecture, Kerstin. And now my colleague Vanessa is going to tell a bit last information.
Very short remarks to make before we adjust the stage and have a short break and wait for our next honoured speaker, whom we are really excited about. I would like to take the opportunity to thank you, Simon. You've missed our thank you. That was part of our opening ceremony, but given that you have made and designed most of the slides we've just seen, and it's been your presentation for all those years, and you've been one of the founding fathers of Sonography Graz, I think you do deserve a big round of applause at this point. Thank you. And now we'll take a really short break, and then we'll be back. Thank you.